this lecture, we talk about rheumatic heart disease and the mitral valve. Why are we talking about them? The reason is rheumatic heart disease is very common in the developing nations, and India is very much afflicted by it. And rheumatic heart disease commonly involves the mitral valve, leading to changes in the physiology of the patient, and the patient behaves in a very different manner as far as the hemodynamics are concerned. So as we were talking about rheumatic heart disease and the mitral valve, so let's go ahead. What are the lecture objectives? The lecture objectives are to understand the anatomy of the mitral valve, the physiology of the mitral valve and its affection, know about rheumatic fever, understand the pathophysiology of valve involvement in rheumatic heart disease, and know about the clinical presentations of rheumatic fever. As I said earlier, rheumatic heart disease is very prevalent in our country. And what happens with rheumatic heart disease is that it results in valvular damage, and this valvular damage is caused by abnormal immune response to group A streptococcal infection, usually during childhood. Although it is said that this disease is associated with poverty and it has disappeared from the wealthy countries, its burden remains a major challenge in the developing nations. The mitral valve is commonly afflicted by the autoimmune response. And this autoimmune response causes structural damage and derangement of valvular function. Once there is an autoimmune response and there is structural damage, it results in fibrosis and cicatrization of the valve structures and in the endothelium. Fibrosis and cicatrization causes anatomical distortion, making the valve functionally incompetent. You can categorize mitral valvular disease into basically two parts. It can be either a stenotic mitral valve disease or it can be an incompetent mitral valve. But we have to remember that a third or probably more patients present with both the lesions. Mitral stenosis represents a pressure overload condition, whereas mitral insufficiency or mitral regurgitation represents a volume overload state. As you can see here, it's volume overload or pressure overload, and thus the pathophysiology, clinical manifestations, and the management differ significantly in the two lesions, and they behave opposite of each other. When we talk about mitral valve, we should know and understand its anatomy. If you look at the mitral valve, if you look at the structure of the mitral valve, it has got basically two leaflets, the anterior leaflet and the posterior leaflet. And these leaflets are joined together at what are called as commissures, the anteromedial commissure and the posterolateral commissure. The mitral valve is held, the cusp of the mitral valve is further held by chordae tendineae, which attach the mitral valve, the free edge of the mitral valve, to the medial papillary muscle or the lateral papillary muscles. So basically the muscles control the opening and closing of the mitral valve. This is something important to remember because the pathophysiology affects all these structures, and all these structures are said to be parts of the mitral valve apparatus. If you look at the mitral valve from the surface, from superiorly, then it looks something like this. Once it is closed, you've got a large anterior leaflet and a comparatively small posterior leaflet. However, the posterior leaflet is divided into three segments. You see, 1, 2, and 3. When you look at the anatomy, then you'll see that the bundle of his lies very close to the mitral valve. Similarly, the left coronary sinus and the non-coronary sinus of the aorta lie very close to the mitral valve. If you look on one side, on the right side of the mitral valve, then you'll find that the circumflex artery lies very close to the mitral valve. Why is it important? It is important from a point of view that during surgery, in case the surgeon is not careful in taking sutures, he may either take this artery into his suture, or he may take the bundle of his, causing if the artery is taken into its or is damaged or is taken in the suture, it will cause an MI, or it may cause bleeding if it is just injured. If he takes the bundle of his or part of the bundle of his, it will cause arrhythmias in the postoperative period. Coming to a little bit of physiology of the mitral valve. Whenever we talk about physiology of any structure in the heart, we should remember the Frank-Starling relationship, which is the basic relationship, is one of the basic things to remember whenever we talk about the heart. What is the Frank-Starling relationship? The Frank-Starling relationship is basically a relationship between the volume of the heart chamber and its output. So, in case the end diastolic volume of the heart, that is the filling of the heart, or the right atrial pressure of the heart is more, it gets more on this side, the cardiac output increases. But it increases up to a particular point. Beyond a particular point, in case the end diastolic volume increases, it will not cause an increase in the cardiac output any further. In case you give an inotrope to a patient, then what happens is positive inotropy will increase the cardiac output further, but this increase in cardiac output can occur only up to a particular range. Beyond that range, in case you give more filling or you give more inotropy, it will not increase the cardiac output anymore. Coming to the pressure volume loops of the cardiac cycle. This is again very important, because unless you understand the pressure volume loops, it is difficult to understand how the heart behaves in the cardiac cycle with various lesions. Remember, the volume loop starts here. This represents the end systolic volume. The end systolic volume is about 50 to 60 ml, and this is the period of diastole. At the end of systole, when the heart starts getting filled up, the volume starts increasing in the chamber of the left ventricle and keeps on increasing. However, a thing to remember is the left ventricular pressures do not go up initially. They may go up a little bit at the end of this filling phase. After this filling phase starts the isovolumic contraction phase, which is the first part of systole. So during isovolumic contraction phase, the mitral valve is closed, that is, the filling has stopped, so volume does not increase anymore. However, the pressure increases in the left chamber of the heart. And when the pressure reaches the diastolic pressure, the aortic valve opens up and the heart starts ejecting, which is called as the period of ejection. So the heart starts ejecting at this phase. This ejection, as the heart starts emptying out, this ejection starts going down. And when the pressure falls in the aorta, with the ejection getting lesser and lesser, the aortic valve closes, which again restarts the diastole. So the aortic valve closes, and once the aortic valve closes, there's a dramatic decrease in the left ventricular pressures, because the muscles are no longer contracting and the volume is not there in the left heart anymore. So if you look at the total area, this total area reflects the stroke volume which was ejected by the heart. Coming to rheumatic fever. The global incidence of rheumatic fever in children aged 5 to 14 years is roughly 3 lakhs to 3.5 lakhs per year, although the incidence varies substantially from region to region. Rheumatic heart disease is said to cause at least 2 lakh to 2.5 lakhs premature deaths every year, and it is a major cause of cardiovascular death in children and young adults in the developing countries. Acute rheumatic fever usually occurs 3 weeks after the infection with group A streptococcus, that is the group A streptococcal pharyngitis, and it can affect the joints, skin, brain, and the heart. Rheumatic fever manifests as a combination of fever, polyarthritis, carditis, chorea, erythema marginatum, and subcutaneous nodules in patients about 3 weeks after the onset of pharyngitis. A family history of rheumatic fever makes the risk of disease 5 times greater than that of an individual who has had no such hereditary taint. This is a very important examination question, and we should remember this. These are called as the Duckett-Jones diagnostic criteria for rheumatic fever. So there are major criteria and there are minor criteria. And mnemonic for remembering this is to remember this mnemonic, Jones-Caffey-Paul. So what is Jones-Caffey-Paul? Jones represents the major criteria. So joint involvement, O because it looks like the heart is myocarditis, N is nodules, subcutaneous nodules, E stands for erythema marginatum, and S stands for Sydenham chorea. While the minor criteria are represented by the mnemonic Caffey-Paul, so C represents an increase in CRP, A is arthralgia, F is fever, E is elevated ESR, P is prolonged PR interval, A is anamnesis of rheumatism, that is rheumatism, the features of rheumatism, and L is leukocytosis. What are the diagnostic criteria for rheumatic fever? In case the patient grows group A streptococcus in the throat culture or has elevated ASO titers, that is anti-streptolysin O titers, if that is combined with the presence of 2 major criteria or with the presence of 1 major criteria and 2 minor criteria, it is called as rheumatic fever. We talked about the autoimmune response. Why does this abnormal autoimmune response occur? Antigenic mimicry along with an abnormal host immune response is the cornerstone of the pathophysiology of rheumatic heart disease and is based on the triad of group A streptococcal strain, a genetically susceptible host, and an aberrant host immune response. This molecular mimicry takes place between streptococcal M proteins, which are present in the group A streptococci, and several cardiac proteins. The common cardiac proteins are the cardiac myosin, tropomyosin, keratin, laminin, and vimentin. Nearly half the patients who have rheumatic fever have a cardiac involvement, and this cardiac involvement is mainly of the valvular endocardium. Patients exhibit hallmarks of acute carditis such as sinus tachycardia and low S1 sound due to a prolongation of the PR interval. A pansystolic murmur or mitral regurgitation suggests rheumatic valvulitis. Pericarditis is also common, and it is characterized by the patient complaining of chest pain, and you may hear a transient pericardial frictional rub on auscultation. Talking more about rheumatic heart disease, the prevalence of rheumatic heart disease worldwide is said to be 15.6 to 19.6 million. And the prevalence is highest in adults in the age of 20 to 50 years. It is said to be highly prevalent in the sub-Saharan Africans and indigenous Australians, the Aborigines. In Asia, rheumatic heart disease is prevalent in the community, and the prevalence rate is said to be 12 per 1,000 people. Although the initial attack can lead to severe valvular heart disease, rheumatic heart disease usually results from a cumulative valvular damage. So this is very important to remember. Rheumatic heart disease usually results from a cumulative valve damage due to recurrent, less symptomatic episodes of acute rheumatic fever. It's not one episode only, it's multiple episodes of rheumatic fever which are recurrent in nature. Mitral valve incompetence is said to be the most common valvular lesion in patients in the early stages of rheumatic heart disease. Mitral valve incompetence, that is MR, is most common when the patient develops the disease in early stages, and mitral stenosis occurs generally in patients in late stages. Although rheumatic mitral stenosis has been described in adolescence, mitral stenosis usually develops late as a result of persistent and recurrent valvulitis with bicommissural fusion. So this is very important. In mitral stenosis, what is important is the fusions of the commissures of the mitral valve. The bicommissural fusion is a very important feature of mitral stenosis. Rheumatic mitral incompetence presents more commonly in the younger population, while mitral stenosis, as I said earlier, usually presents around the age of more than 20 years. Now, what happens in the mitral valve after the involvement with rheumatic fever? There are morphological changes in the mitral valve, which include thickening of the leaflets of the mitral valve, thickening of the subvalvular apparatus of the mitral valve, that is the chordae tendineae and the papillary muscles, shortening of the chordae tendineae, fusion of the commissures, the two commissures of the mitral valve, calcification of the valve occurs later, and all this lead to a restricted leaflet motion. A thing to remember, as I said earlier, is that some degree of commissural fusion is always present in rheumatic mitral stenosis. Thank you.